All right, the next section is on regulation of hydrogen ion balance. Okay, so we're basically breaking it down so you guys get to see sodium balance, water balance, potassium balance. And now we're talking about the next section, which is about hydrogen ion balance. Okay. The first thing is acid and bases tend to obey the basic principles that if you put in acid into your body, you have to put out the same amount of acid to get rid of it. Okay. So where is your acids being produced and how are you producing bases? Well, for something, metabolism is a big factor. Okay? The other factor that's important is the activity of the GI tract and how you're processing your ingested foods. And eventually the kidneys are the actual end the system to actually maintain your acid-base balance for long term. Because it actually is the one that's responsible for removing a lot of the hydrogen ions that are being made. Okay, so that's your output system. But most of your input is actually by the GI tract, by actually what you eat, and also by metabolism. GI tract, some people actually can change their pH in their bloodstream just by what they eat. Some people tend to, for some reason, and it's unclear as to why, will eat a lot of things that have acids in them. Okay? And as a consequence, they actually change their pH to a more acidic milieu, and their kidneys tend to work harder to remove the hydrogen ions. But eventually, if you put enough acid in your system, you can actually overwhelm it. Okay? So people that are drinking a lot of like lemonade a lot, that's pretty acidic. Okay? That also begins to have that effect. Okay? But the actual main mechanism that doesn't allow your body to immediately become severely acidotic when you basically take in a big drink of lemonade is that you have a buffer system. Okay, the buffering system is in your blood, and that system is the CO2 bicarbonate system. Okay, this allows for volatile acids to be rapidly removed via the lungs. But in addition to that, you have other buffers that are in your bloodstream, such as proteins and phosphates. Okay, those are negatively charged molecules that can absorb hydrogen ions very easily. Okay, so those are also found in high concentrations in your vascular supply. The body really tries to do a good job of trying to maintain the pH very tightly balanced because it really affects the ability for the actual cell receptors to function properly or not. So if you change the acidic milieu around the cell, that means you actually are going to alter the actual receptor capacity as well as the protein channel capacity of those cells. CO2 is a volatile acid, and because of that, it can be removed very nicely by the lung. We talked about that before in the respiratory section. And CO2 can act like an acid because it basically converts when it combines with water. When it combines with water, you can convert it into H2CO3, which then converts into H plus HCO3 minus. So this is what makes CO2 acidic. Okay, so if this gas here can be removed via the lung and does a very good job. So really, the kidney is not responsible really for maintaining CO2 balance all that much. What the kidney is responsible for is that it produces high concentrations of bicarb as well as secretes this as well directly. So CO2 itself is not responsible for that in the sense that this is removed by the lung. Okay? Now, non-volatile acids, on the other hand, can't be removed by the lung. Okay? All the non-volatile acids, such as the organic acids that you produce, okay, has to be removed by the liver and the kidney. Okay? What the liver does basically is it converts anything that's non-water soluble into a water soluble compound. Okay? So then the kidney can get rid of it. Now, CO2 and bicarbonate are independent of each other, okay, in the sense that CO2 is regulated by the lungs, which I showed you previously, but bicarb itself can be actually regulated by the kidneys. Okay? In addition to that, free acids or fixed acids, such as non-volatile acids, are basically removed by the kidney. The sources of your primary fixed acids and bases are metabolism of dietary protein, metabolism of dietary weak acids, and when your GI is producing high levels of secretion of acids from certain organs like the stomach, or sometimes by base-producing organs such as the pancreas and the large intestine. Okay? In addition to that, you have anaerobic metabolism that sometimes may take place. This is not the normal mechanism. This is anaerobic, which means that you're not getting oxygen, and that's conversion of carbohydrates and fat via lactic acidosis to lactic acid. Okay? And then you have ketone bodies, which is the byproduct of lacking of insulin, where you get ketoacidosis. Okay? These are all forms of anaerobic metabolism or conversion of excessive amounts of carbohydrate by the body in situations with inadequate levels of insulin. What your body is going to try to do is that it normally begins to try to convert inside cells by combining water and CO2, and it uses a specialized enzyme called carbonic anhydrase. We already talked about one place where that takes place, via the Haldane effect. Okay, what's that called? The red blood cells. Red blood cells use Haldane effect to convert CO2 and water to convert it into carbonic anhydrase into bicarb and hydrogen ions. Okay? Now, the hydrogen ions is what the body wants to get rid of, and bicarb is what it wants to return back into the actual plasma, okay? Because that's going to act like a buffer. So what's going to happen over here, this is the urine side, okay, is that hydrogen ions is going to be removed as much as possible into the urine. So without the advent or the establishment of having high levels of carbonic anhydrase in your system, you really can't get this reaction to take place in fast enough rates to really effectively remove hydrogen ions out of your system. So carbonic anhydrase is one of those critical enzymes responsible for conversion of CO2 and water into H2CO3. Okay? What they miss in the step is, which is here, and then that breaks down to this. Okay? Now, under normal conditions, the normal contribution of tubular segments to renal hydrogen ion balance, the proximal tubule reabsorbs most of the filtered bicarb, 80% of it. Okay? And then it produces and secretes ammonia. Okay? So what does ammonia do? Ammonia has attached to it, this is ammonium, okay? That's ammonia to ammonium, okay? And that has a hydrogen molecule that's being bound. So ammonium is a molecule that does not like to come back because it's basically charged. Okay, versus the neutral molecule like this, if it didn't, okay, it would basically cross back through. Okay? But once you add the hydrogen molecule to it, you're trapping it by giving it a positive charge. And that traps it in the urine. Okay? And that also helps with enormous amounts of hydrogen ion to be secreted and bound to the urine. This is what makes the urine smell. Okay, it is ammonia inside the urine that actually gives it this odor. Okay? Now, what is it happens in the proximal tubule? What kind of mechanism is taking place? Okay, again, this is the urine side here. This is the plasma side here. Okay? What you see is the carbonic anhydrase does convert it into hydrogen ions in bicarb. Okay? The bicarb is rapidly reabsorbed towards the plasma, and the hydrogen ions is pushed out via an antiport, which is a sodium hydrogen ion antiport mechanism, and then the hydrogen ion, which is also releasing, or it's actually not releasing it, it's not secreting it. You have the other molecule, which is NH3, floating around in here, and when it binds to the hydrogen ion, it converts into NH4+. And that molecule essentially can't move out of the urine. It's stuck. Okay? So it acts like a sink. The reason that's important is why? It's removing this quickly. Okay? So in the proximal tubule, it actually is helping maintain the gradient. It's helping it along a little bit. Okay? Now, the thick ascending limb of Henle reabsorbs the second largest fraction of filtered bicarb, which accounts for about 10 or 15% more bicarb. So at this point, you're at 90 to 95% of your total bicarb that's been filtered has been reabsorbed. It shows you that the kidney is very serious about keeping bicarb. It's one of the few molecules that, by the point of hitting the thick ascending loop of Henle, it has already reabsorbed 95% of the material that's actually filtered. Okay? It is also secreting hydrogen ions at tremendous amounts as well. Okay? So urine is acidifying very nicely at that point. Okay? Now, once it reaches the distal convoluted tubule in the collecting system, you basically reabsorb virtually all the remaining filtered bicarb. So you're at 100% usually by the time, under normal circumstances, by the time you hit the end of the collecting duct system of all the bicarb that you filtered. Okay? Now, the cells responsible for that were called the type A intercalated cells. And they also, the type A, produced titratable acids that are going out. Okay? In addition, you have a different kind of cell that sometimes, every once in a while, most people are not alkalotic. Most people are acidic. Okay? So this system is set up for mostly people that are acidic. But every once in a while, you might get in an environment where you develop a nice eating habit for all you're doing is you're eating base. Okay? So you're drinking a lot of milk, or you're drinking a lot of, what's it called? Not sour milk, was it? It's got a very high base in it. Okay? But anyways, there's different kinds of things you can drink that have a lot of base in it. And as a consequence, a person is actually developing alkalosis. So at that point, you want to get rid of the bicarb. Okay? So in that sense, there's another kind of cell called the intercalated B cell. Okay? The intercalated B cells are basically the same thing as an intercalated A cell, but the difference is that the actual cell is flipped. Okay? And this job is actually to remove excess bicarb and to actually absorb hydrogen ions. Okay? So type A cells are the ones that are normally pulling bicarb back in and secreting hydrogen ions, but the type B are the ones that flip and allow for this bicarb to be excreted. Okay? Normally you secrete hydrogen ions into the distal convoluted tubule, and you also secrete protons or bicarbs to balance the net input into the body. Okay, so here's a type B intercalated cell, and you can see the difference of it is here. Here's the urine side again, and this is the plasma side. Okay, in this situation, if you get an activation of the type B intercalated cell, when you have your carbonic anhydrase, it releases your bicarb. Instead of being on this side, which is then going out, okay, it's actually, the system is set up backwards. And now the bicarb is actually being secreted out into the urine. Okay. The hydrogen ion is also being pumped out into the plasma. So that's the double effect of actually improving your acid-base balance if you're alkalotic by removing your excess bicarb in the urine and also pumping hydrogen ions back into your plasma. So that only occurs very rarely. It only occurs when you're really alkalotic. Okay. So most patients in clinical situations are acidotic, not really ever alkalotic. Okay. The lumen transport of hydrogen ions, if you look at the previous pictures, is different than bicarb in the sense that it's the proximal tubule has a job of doing what's called a sodium hydrogen ion antiport, which means that the sodium will come into the cell and the hydrogen ion will go out of the cell. That's called an antiport system. And that's set up in the proximal tubule. And that hydrogen ion then binds eventually to things like ammonia. This is a nice picture showing you 9.2, the same thing I just drew for you. Okay. You don't have to know all the specifics. I just want you to know that hydrogen ions are pumped. They're going, what does this mean though? If I'm going this kind of mechanism, what does that mean to you? It's using indirectly an active transport mechanism. Okay? Because what's happening here is you have a sodium-potassium ATP pump. This is pumping out the sodium here. Okay, and it's establishing the gradient. So it needs to establish this gradient Because what's happening to the urine hydrogen ion concentration in here? It's going way up. So this is going up a gradient, not down a gradient. Okay? So that requires energy. Anytime you start pushing a molecule up a gradient, it requires energy. It's not using ATP, yes, not here, but it's using the sodium gradient. And that sodium gradient is done by active sodium-potassium ATP pumps. Okay? You also have, in addition to that, in the distal tubule, you have a specialized thing called a hydrogen ion ATPase, which means that the type A intercalated cell, the collecting system, is actually pushing hydrogen out via ATP in the distal tubule, and the type A intercalated cells is using a hydrogen potassium ATPase activity. Okay. This is showing you the type A intercalated cells. Okay. Under normal circumstances, they're pumping out the hydrogen ions here, okay, via ATP. Okay, and then this is the other mechanism, which is the potassium's going down, but hydrogen's going out. Okay, this is the same thing we talked about before, where you can actually drive this mechanism to occur in regular cells in the plasma by causing the potassium to push it back into the cell by making the person alkalotic over here. It would then drive this reaction this way, and then it would cause potassium to go into the cell rapidly. It's the same kind of pump mechanism. In the basolateral membrane for bicarb, in the proximal tubule, you have sodium bicarb symporters, and in the distal tubule, you have chloride bicarb antiporters. I don't really want you to know all the specifics on that. I'm just showing you that it's a complex mechanism to maintain hydrogen, the bicarb balance as well as hydrogen balance. Now let's just talk a little bit more about how does hydrogen ion excretion in the urinary buffers and the formation of bicarb. Phosphate is by far the most important non-bicarbonate urinary buffer. Okay? So in addition to bicarbonate, the most important non-bicarbonate urinary buffer is phosphate. Okay? When you have a secreted hydrogen ion combines in the lumen, which is in the urine, with a filtered buffer other than bicarbonate, the overall effect is an addition of a new bicarb. Okay? And it's basically by doing this mechanism of holding the hydrogen ions via phosphate in the urine, you begin to actually produce around 40 millimoles per day of bicarb. Okay? How does it do this? Okay? Here's your filtered phosphorus. Okay? That's in your urine. As it's traveling down, okay, in the urine, it begins to act like a sink and begin to bind to excess amounts of hydrogen ions. Okay? That helps establish this gradient, okay, and drive it and help keep it going. Okay? In addition to that, these are still going up. They're going uphill. They're going up against gradient, and they require ATP in both these mechanisms. Okay? So one of the things that you will eventually see is that when this is being produced, as you're removing the hydrogen ions this way, okay, you're also producing bicarb inside the actual cell lumen. Okay? That bicarb is then excreted back into your plasma as bicarbonate. Yes, sir? Yes, it does. It helps it. You still need the ATP. What it's doing for you is that if you didn't have the phosphorus in high enough concentrations, it would start slowing down the gradient, even the way ATP. Because instead of pushing up against 300 molecules, you're pushing up against maybe 100. Okay, so it's a big difference. Okay, so it acts like a sump. Okay, just like ammonia does the same thing. NH3 also acts like a sump. Instead of, if you just say you have one that's sodium, ammonia, which is NH3, and then you have another one which is phosphorus, which is HPO4 minus. Okay, both those act like a sump. They hold on to hydrogen ions when they come out, and they help keep the gradient not getting clogged up. Okay, ATP can only do so much work. Okay, if you have to pick up 300 pounds, not many people can do that. Okay, If you're asked to pick up maybe 50 pounds, you can do that. Okay, and that's what this system does. Okay. Or actually, if you don't have it, then you can't, even if you have the ATP, it won't push it up the hill. Okay. The hydrogen ion is excreted as well as on ammonia, which we just talked about briefly as well. That also acts like a sump. The liver is a byproduct from conversion of amino acids using an oxygen. It produces usually ammonium, okay, which is NH4 plus, as well as bicarb. Eventually, it converts it into urea, okay, which we already talked about how the kidney gets rid of urea, and then CO2. CO2 can easily be removed by the lung, but the ammonia is still floating around. Okay, the ammonium hits the proximal tubule cytosol, and its glutamine is converted into NH4 plus and a bicarb, and then the actual ammonium is secreted via the sodium hydrogen pump. The bicarb then enters into the basolateral membrane and produces about 10 to 40 millimoles per day of bicarb. So this is the same kind of mechanism as phosphorus. Okay, it's acting as a sump mechanism in the urine, which is accepting the hydrogen ions coming out of the cells, and as a consequence is allowing for the wastage of of hydrogen ion, and also at the same time as a countercurrent mechanism is helping maintain the actual bicarb concentration. So let me show you what I'm looking at here. You got a molecule like glutamine, okay, which is a byproduct of amino acid metabolism. See the glutamine? Okay, that glutamine gets into, let me just redraw this, into the blood on this side. Okay, as the blood's coming by here, it releases the glutamine. Okay, and the glutamine is then uptaken into the actual proximal tubular cells of the kidney. The glutamine is then broken down via an enzymatic reaction to produce NH4 plus and bicarb. Okay, that's a byproduct of this mechanism. Okay, the NH4 plus then is actively pumped via a gradient. This is a energy gradient that you're using, which is an anti-port mechanism, and then this will push it upstream, okay, which increases the ammonium concentration. The other mechanism that also helps establish this, and another kind of mechanism like phosphorus, is that when you let filtered NH3 come over here, okay, when it also releases things like hydrogen ions out here, it acts like a sink, which then also allows other forms of bicarb to come out. Okay, so this system is set up to help in two ways. One is this mechanism, which uses glutamine to convert and produce ammonium, okay, which is then actively secreted out, okay, or the other mechanism where you're actually taking ammonia, NH3, which is an byproduct of metabolism, and act like a sump that also helps provide with bicarb formation, okay, which is what this is right here. I skipped a step. Okay, here's the urine ammonia, and you can see what happens here. It acts like a sump, okay, and it helps produce the bicarb over here that goes into back into your system. Okay. Again, you don't have to go into all the specifics. Just know that it either acts like a sump, which means it actually holds hydrogen ions and it helps remove acid, or sometimes in this example, it actually can take a molecule that is a byproduct of metabolism, and it can convert it in the proximal tubule into ammonia, which then can actually be secreted out as well. Okay. The renal contribution of new bicarb to the blood it occurs in different kind of situations. If say the person is alkalotic, okay, what really happens? Well, what happens in that situation if you're alkalotic is you want to get rid of bicarb. So in this situation, you actually excrete about 80 millimoles per day of bicarb. Okay, so you're actually losing bicarb in that situation. On a normal state, so because you are producing a considerable amount of acid in your body, okay, most of the time you're taking titratable acids and removing them, okay, and you're also removing acid via ammonium, okay, which is Na4 plus. And you're almost secreting almost zero to no bicarb at all in your urine. It's only about 1 millimole per day, so it's very, very small. If you have somebody who develops acidosis, on the other hand, okay, what happens in that situation is that bicarb literally stops being released by the kidney. Okay? What you'll see is you'll see a tremendous amount of increase in the actual free titratable acids getting in your urine. But what's even higher in concentration than that is because some mechanisms become very important, will be things like ammonium. Okay, so ammonium climbs at a much more rapid rate, okay, than it does the titratable acids. Okay? The titratable acids is only a 2-fold increase, versus this is a 4-fold increase. So these buffering, not buffering, but these sump mechanisms can be very efficient in pulling off excessive amounts of hydrogen ions. Okay? What you end up having in acidotic states is you end up wasting a good 200 millimoles per day of acid, of hydrogen ions out of the system, which is considerable. Okay? Your urine pH, look how acidic you'd be. Your urine pH is very acidic at that point. And that alone would maintain your acid-base balance in your plasma. Your plasma pH would still be because your body is trying to maintain a pH normal in the blood at 7.40. Okay? So it's very efficient to do this. Okay? Now, can you overwhelm the system? Absolutely. Okay? If you begin to produce beyond 200 millimoles per day of free acid, okay, that's that's basically non-volatile acid, then that'll overwhelm the kidney. And then you'll start getting a drop in pH. So the person will show signs of metabolic acidosis at that point. Okay, but as long as you're actually removing up to 200 millimoles per day of acid, if you keep it up, the kidney's working frantically to do this, but it's able to keep up. Okay, it's only when you exceed that point that's when the system begins to fail. Question is, what happens? Quantification of renal acid-base balance excretion. One of the things you've got to ask about is how much output of bicarb is going out the urine, and how much bicarb is added by the removal of hydrogen ion by the non-bicarbonate buffers, and how much ammonium is being released. All those are important factors in quantification of how much renal acid base is being excreted. Okay? Normally, like I showed you before, if you have an acidic environment in your plasma, the body's going to try to hold all the bicarb it can, so the actual output of bicarb is going to go to zero. Okay? Anytime you see bicarb in the urine, you have to think that the person's alkalotic. Okay? Or at least is fairly on the normal end of things if it's just a small amount. Okay? But if you start seeing a lot of bicarb being spilled in your urine, you see the pH rising to 8, that person is significantly alkalotic. Okay? And we talked about how much hydrogen ion goes out to non-bicarbonate buffers, which is the ammonia as well as the phosphate. Regulation of renal handling of acid and base is related to changes in CO2 and pH. There is really no nerves or hormones involved in this balance. So if you give a person a kidney transplant, this system kicks in right away and doesn't really require any fine-tuning at all. Okay? So the kidney does a very nice job of maintaining your acid-base balance just by what blood arrives at the glomerular filtration rate. Okay? Of course, needs to have a certain amount of filtration rate to take place, but it does a very good job without any further assistance from the brain or any kind of nervous system effect to make this difference. Things that you may encounter in clinical is when you give somebody lactate ringers, what actually happens. Okay, well, lactate is one of those things that is actually in lactate ringers. Okay, when it actually combines with hydrogen ion, it produces CO2 and water. So most of the time, patients can actually ventilate this stuff off, right? It's simply a volatile acid. Okay, So that's not usually a problem. Okay? In addition to that, you can actually leave some additional bicarb behind, which acts to help diminish the chance of getting metabolic acidosis. So lactate ringers is a nice solution to use in situations where you're going to develop acidosis, which almost invariably occurs from any kind of operative procedure. Categories of acid-base balance, we've broken down into respiratory acidosis, which we've talked about before. I'm going to briefly go over that, and that's basically if your CO2 levels are rising because that's a volatile acid. If you get respiratory acidosis, you can get that from damaged respiratory drive centers, obstruction of the conducting system, or inadequate ventilation. On the other hand, respiratory alkalosis is when you hyperventilate and you start removing your excess amounts of CO2, and as a consequence, a person's pH begins to rise. Metabolic acidosis is due to the failure of the system to get rid of hydrogen ions. It could also be from renal tubular acidosis, such as chronic renal failure, diseases like Addison's disease, and hereditary disorders include Fanconi syndrome. This leads to excessive hydrogen ion production and leads to metabolic acidosis. Things that also produce excessive amounts of hydrogen production include diabetes, and where you get fats converting into acetoacetic acid, where your patient doesn't have enough insulin levels and they get ketoacidosis. Okay? These are forms of metabolic acidosis. In addition, you can take poisons such as aspirin or methyl alcohol, which forms formic acid, okay? And you can also get the loss of base from diarrhea. It's usually the most common form of acidosis in the world, okay? And also severe vomiting. Okay? So actually what causes a lot of deaths in patients in the world by far is diarrhea, and that causes a severe metabolic acidosis. Metabolic alkalosis is very rare. It sometimes can be induced by diuretics, all except carbonic anhydrase inhibitors. They also can occur from excessive aldosterone, which causes metabolic acidosis due to increased sodium reabsorption and increased hydrogen ion secretion. You can also get acid alkalosis from vomiting, because what you're losing is the hydrochloric acid that's in your stomach, and the body begins to try to reproduce that, and it begins to waste hydrogen ions as a consequence. And the other reason is if you take an excessive alkaline drug ingestion. That's pretty hard to do, though. How do you correct these problems? Is correct the condition. Please don't just correct the acidosis with bicarb, okay, if you're giving that. You think about what the main cause is first. How do you actually do that? Is check your blood gas and look at the BMP. What's a BMP? When you look at a BMP, that's a basal metabolic profile, okay? That's going to have the values of sodium, potassium, chloride, bicarb, okay, BUN, creatinine, and glucose. One of the things that I want you to look at is another way this is also written is CO2. Okay? If you look at this value here, okay, that value should be anywhere between 24 to 28. Okay? If you see that number saying it's 40, what does that mean? It means that person has long-term CO2 retention, okay, and actually has renal compensation. So that person has a respiratory acidosis that is metabolically compensated for. Okay, so it's a very easy way, without even doing a blood gas, you know you got a problem. If on the other hand you see that this number drops down to, say, 16, okay, that's also a very serious condition. You got to put your head up and figure out, hey, what the heck's going on here? Why is this number so far down? And that's usually a metabolic acidosis that's not been compensated for. That person's in shock until proven otherwise. Okay, so that's bad. Shock. Okay, this tends to be respiratory acidosis. Okay. Okay, so you got to pay attention. The BMP is a very helpful tool without even drawing a blood gas. Of course, a blood gas gives you definitive values such as pH. It gives you the PA, CO2, okay, which is how you want to make sure you're looking at this, plus the bicarb in it. Those are all interrelated, and you're expected to know that as part of any kind of acid-base question you may have. Separate that from PaO2 and saturation. That has to do with oxygenation. Okay? And this has to do with ventilation. Okay, ventilation has to do, of course, with CO2 removal, okay? But oxygenation is a different concept. The Henderson-Hassebach equation, you can go ahead and memorize that if you want to, but not needed for this exam. Okay? Some people do. What I tend to do to teach you is to think about in the values, well, what it's trying to tell you. Okay? It's in direct relationship. It's showing you how the CO2 is related to bicarb formation, okay? And how it's inversely proportional to affecting pH. Okay? These are the different clinical scenarios for different forms of acid-base balance. Metabolic acidosis, anytime you encounter it, you have to do what's called an anion gap, which we've talked about before, so I'm not going to go into a lot of detail about that. If you have an increased anion gap, things that you have to look for is lactic acidosis, ketoacidosis, or from poisoning. Most people in the world die of normal anion gap metabolic acidosis, which is diarrhea, which is the most common cause of death. Okay? Renal tubular acidosis is a little more rare. Excessive ammonium chloride administration, again, that's rare. And drainage from the ureterosigmoid ostomy. So you got a situation where the urine is actually now going to the sigmoid, and that's actually causing this anion gap metabolic acidosis. And the other thing is a drug such as acetazolamide being administered in excessive amounts. The metabolic alkalosis are usually due to diuretics, corticosteroids, NG suctioning that's excessive or excessive vomiting, or severe dehydration. Respiratory acidosis, of course, we just talked about before, and respiratory alkalosis as well, so I'm not going to go into that. Two more factors causing kidneys to generate and maintain metabolic alkalosis are things that influence the extracellular volume contraction. Okay? These are very rare symptoms. Okay? So high levels of aldosterone sometimes can lead to hydrogen ion secretion that are too excessive, and it causes a metabolic alkalosis. The other thing that can occur is if you excessively vomit, you not only are wasting chloride, but you're also causing hydrogen ions to be released in massive amounts via your vomit, okay? And as a consequence, you can get a metabolic alkalosis. Some people can actually abuse diuretics, and that also will cause depletion of chloride, which also depletes your hydrogen ion. Some disease states such as causes increased aldosterone levels, which then stimulates potassium depletion. It can also induce this kind of metabolic alkalosis as well. So this is a nice picture showing you what happens with chronic vomiting or excessive use of diuretics. Two things will happen is that you'll get potassium depletion. That will cause an increased tubular secretion of hydrogen ions as a consequence to that. You see, that's a major effect, okay? And that eventually leads to a generation of metabolic alkalosis. The other mechanism that you see here is the volume contraction causes not only the renin-angiotensin system to be activated, but it also causes an increased reabsorption of all filtered bicarbonate and contributing to a new bicarbonate into the bloodstream, which ends up causing a significant metabolic alkalosis. But by far the biggest reason for this development is that potassium depletion can cause a significant amount of increased tubular secretion of hydrogen ions.